can I have my first slide up, please? I want to thank the Medical Center for giving me this wonderful opportunity. I'm very honored and very pleased, and I want to thank Sam very much for those wonderful, very generous words of introduction. I want to tell you first about how big a problem chronic kidney disease is, and then what we might be able to do about it, looking at some conventional approaches to modulating it and some novel areas where maybe we can reach even further. This is the data of what is happening with end-stage renal disease in the U.S. Actual data up till 2004 that was just published late last year, and you can see this curve that has risen over the last 20 or so years is reaching astronomical proportions, particularly disease related to diabetes or hypertension. But it's not just happening in the U.S. If you look at projections worldwide, we have an even sharper, steep slope ahead of us in terms of increasing the world population of patients who are on end-stage renal disease. And if we're not able to do something about that, they will die if they don't have access to dialysis or to transplantation. If we look at why that is, we can understand that regardless of what the primary disease mechanism is, once you reach a certain point of loss of your kidney function, the remaining kidney tissue starts to scar on its own, whether it is diabetes or lupus or kidney stones that has caused the initial damage. And these are regression lines from individual patients. This is the renal function, 1 over serum creatinine, and this is time. And you can see that some are reaching end stage very quickly, some are more slow, but they're all going downwards on a downward slope. And it used to be that this was all that we could hope for. When I was on the wards with Bill Stone as a third-year student, I would get several of these points from patients we saw in clinic, and I would calculate how long would it be till they reached the DDT line, death, dialysis, or transplantation. This is what it looks like when you're looking at an individual patient's biopsy who has chronic kidney disease. These used to be glomeruli, the filtering units of the kidney. They're all obstructed by extracellular matrix scarring. These used to be functioning tubules. They're now atrophic with phenomenal interstitial fibrosis and inflammatory macrophage infiltrate. If we look at the individual patient, this is what it looks like. This is obviously old. It's pre-electronic record, but it gives you a sense of the mass of morbidity and mortality for individual patients. I first saw this patient as a resident when she was 5 years old and presented with proteinuria. She turned out to have a progressive scarring disease called focal sclerosis, had a stormy course on peritoneal dialysis, got a kidney transplant. She was able to have a baby here in her early 20s, but now is reaching end stage again with her transplant undergoing the same type of progressive scarring. If we look at this, this is one such patient who has chronic kidney disease. He is younger than many of you in the audience. He's in his late 20s. This is his seeing eye dog because he also is blind due to his diabetes. The machine in the background here is a diabetic, is a dialyzer, and his wheelchair is off on the side that he uses when he gets too tired because he's amputated some of his toes. When we look at what's likely to happen with chronic kidney disease, it's not a panacea to have dialysis or transplant. Look at the mortality here of expected life expectancy for chronic kidney disease shown in white. At age 49, you might have about 8-9 years left, compared to nearly 30 if you're a healthy 49-year-old. Of course, you have fewer years left when you're 59, but look at the diseases that were wedged in between, lung cancer and colon cancer. These are diseases that have horrible morbidities and mortalities. So what can we do about it? Many investigators have looked at many mechanisms of that progressive ongoing downward slope of loss of function in chronic kidney disease. We know that systemic hypertension is important. Turns out that the blood pressure in the glomerulus is also important. Their growth factors, macrophages. Proteinuria is not just a marker of injury in the glomerulus. It can also cause progressive scarring to some extent. Reactive oxygen species and innumerable other mediators. But an interesting thing that they all share in common is they all can be modified by the renin-angiotensin-aldosterone system. Has effects beyond blood pressure on some of these other inflammatory and proteinuric and reactive oxygen species mediators. So, looking at the data then of what happens when patients are treated with inhibitors in the renin-angiotensin-aldosterone system, this example from ACE inhibition, which is a summary from many clinical trials and observations show that that downward slope could be ameliorated. It could be slowed, prolonging the time until end stage was reached. And moreover, what was very interesting was that when meta-analysis was done, it wasn't just dependent upon the blood pressure. Comparisons with other treatments, with nonspecific antihypertensives, didn't show this same salutary effect. So if we could ameliorate and slow down progression by inhibiting angiotensin, is it possible that by giving even higher doses we could do something better? Could we even reverse sclerosis? Is it possible to be so audacious to think in that term? It used to be that people would say that a scar is fixed. You can't do anything about it, particularly in the glomerulus. So to first address this question, I decided to go to the literature. This is not a senior professor in the Department of Pathology. We do have senior professors in our department, but this is actually Maimonides. Do any of you know who Maimonides was? He's the father of medicine, of astronomy, of mathematics, of astrology, and he was a very wise person, I think. First of all, he and his family fled Cadiz, Spain, to escape persecution because they were Jewish, and they went to Cairo, which at that time was a very open society that was very tolerant. And he practiced medicine, he wrote treatises, he taught astrology, astronomy, and he also was very savvy because the written record has that he turned down the offer to be King Richard Lionheart's court physician in England. I don't know if they had socialized medicine in England then too, but he stayed in Egypt, and he pronounced many great truths. I'm going to share with you one of them. He lived in the 1100s. Man, meaning the species, he was a very egalitarian person, should believe nothing which is not attested to, 1, by rational proof as in mathematical science, 2, by evidence of the senses, and showing how savvy he was politically, 3, by authority of prophets and saints. Now, as you've heard from Sam, I've been at Vanderbilt a very long time, and I know the very high level of achievement of my colleagues, my peers, my students, my mentors, but I don't think I can put any of them in the saint category. I've known them for a very long time, I told you. Some of them do have a bit of the prophet in them, but I'm going to try to stick to number 1 and number 2 in exploring the possibility that sclerosis could be reversed. So if we are going to regress sclerosis, we have to do 2 things. We have to decrease the matrix that is accumulated in the scar, and we have to restore capillary area. In the first part of my talk, I am going to talk about the effects and the mechanisms and the experiments we have done to look at the matrix component. And in the second portion of my talk, I'm going to talk about some new data where we are investigating what could be done about the capillary area remodeling. This is a schema of a glomerulus. Here is the afferent arteriole coming in, the efferent going out. As my students might remember, the way I can tell that is because this arrow points in, this arrow points out. In morphologic sections, it's a little bit harder to tell. But within the glomerulus, we have complex capillary loops. They're lined by endothelial cells. There's a basement membrane. There are podocytes, the visceral epithelial cells on the outside, which are highly specialized and terminally differentiated. They don't proliferate very readily. And we have mesangial cells here, shown in this green, with matrix surrounding them, and they're kind of the musculoskeletal system of the glomerulus. So if we are going to remodel a glomerulus that is scarred, we have to consider the potential obstacles and the things that could promote remodeling. So we know that in a glomerulus, we have proteases that are normally expressed there. That is great for remodeling scar, but unfortunately there also are protease inhibitors, particularly with aging or advanced glycation end products such as seen in diabetes. That makes it a little bit harder to break down proteins. We know that the cells can proliferate. All of the glomerular parenchymal cells have some capacity to proliferate, even in advanced scarring. By labeling studies, we've shown that there's turnover of cells, but unfortunately, not all of the cells can replenish equally. The podocyte, as I told you, is particularly recalcitrant, and it's a little bit more difficult to grow new podocytes. And lastly, after term birth in humans, we cannot grow new glomeruli, but we can grow new segments of the glomeruli. So in theory, we should be able to take a glomerulus that is partially scarred and be able to remodel the scar and increase growth of the remaining cells. So this is our schema of our hypotheses. We think that segmental scars, and in old experiments with mathematical analyses that I won't go into, we have shown that this remodeling potentially could take place if less than half of the glomerulus is scarred. If more than half of the glomerulus is gone, it seems much more unlikely. This segmental scar then could break down, shown by the stippling, and then the remaining open loops could potentially branch and lengthen so that we have the glomerulus in the end with less scar and more functioning filtering surface area. So how are we going to go about this beyond controlling the blood pressure, which we know clinically is of prime importance? I think we have to do a combination of things. We have to decrease the matrix production, and that is achieved in large part by inhibiting the key growth factors that modulate matrix synthesis. I've listed my favorites here: angiotensin, platelet-derived growth factor, transforming growth factor beta. The dots are for you to put in your favorite factors, because there certainly are many others that can increase synthesis of matrix. And then we have to increase matrix degradation. We can do it directly by enhancing collagenases or proteases, or we can inhibit their inhibitors. And the key inhibitors that are relevant to the glomerulus, we think, are PI1, plasminogen activator inhibitor 1, and TIMP, tissue inhibitor of metalloproteases. And if we achieve this decreased production and increased degradation, we should be able to have decreased scar. So what about PI1? You may think about it as primarily the physiological inhibitor of tissue type and urokinase type plasminogen activator in the circulation. We take advantage of its known effects to promote clotting by antagonizing it, giving TPA, UPA, type derivatives to patients with acute coronary artery syndrome. It has many sources, including the endothelium, vascular smooth muscle cells, the liver, platelets, macrophages, and many of the parenchymal cells in the kidney. It turns out from elegant work from Doug Vaughn and Nancy Brown and some of our studies and some studies we've done in collaboration with them that the renin-angiotensin-aldosterone system is strongly linked to PI1 and to fibrosis. Angiotensin induces PI1 in vitro and in vivo, a direct induction that's mediated by the type 1 angiotensin receptor. And Nancy Brown has shown that aldosterone enhances this angiotensin-induced induction of PI1, and her studies point to a GRE promoter element in the gene of PI1 that mediates this effect. We know epidemiologically that increased blood levels of PI1 are strongly linked to increased cardiovascular disease, not just thrombotic disease, but the sclerotic sequela. And we have data that I'll show you that PI1 expression in cells modulates collagen. More expression, more collagen, knocking out the expression, less collagen. Let me show you that data that Li Jun Ma in my lab and I have done. These are from glomerular endothelial cells. We have control cells, cells that have been effectively transfected to overexpress PI1, and a control adenovirus. And they've been exposed to normal conditions with normal glucose NG, an osmotic control or high glucose, with the idea in these experiments being that high glucose is a very pro-fibrotic stimulus linked to diabetes. And you can see here that if we compare the normal glucose conditions of the wild type to the hypertransfected PI1, there's much more collagen being produced even at baseline. And if we compare even further then, under this pro-fibrotic stimulus, the upregulation of collagen is quite dramatic. Conversely, when we use PI1 knockout cells from the glomerulus, in this case the podocytes, you can see when we stimulated with angiotensin II in wild-type cells, we had a remarkable increase in collagen synthesis. And if we stimulated the PI1 knockout cells from our knockout mice, there was no response that was significant in response to angiotensin. So at least at the cell culture level, the presence or absence of PI1 was directly linked to synthesis or absence thereof of enhanced collagen. We also then thought about what the mechanisms could be of this PI1 imbalance and fibrosis, and our schema is shown here. These are the known mechanisms of PI1 to inhibit TPA and UPA. TPA and UPA work by inhibiting the transition of an active zymogen precursor plasminogen to plasmin. And plasmin, as it turns out, is a very promiscuous molecule. It doesn't just affect fibrinolysis. It also causes proteolysis. We also have results from the cancer literature and from my colleague Allison Eddy at the University of Washington that UPA by interacting with its receptor UPAR, could mediate breakdown of matrix. So if we have a lot of pi1, we are going to put the brakes on the naturally occurring proteolysis. And if we inhibit pi1, as I've already shown you in cell culture, we thought that there was a possibility that we could affect the proteolysis in vivo. So first we looked at pi1 knockout mice that we had bred onto a genetic background strain that makes them susceptible to this model of 5/6 nephrectomy. It is a model where we remove 5/6 of the kidney mass. So the tiny little bit of kidney that remains undergoes dramatic changes with hypertension, hypertrophy, and progressive scarring happens, just as it would in humans who have initial loss of many nephrons from their disease. And you can see here in the wild-type mice shown on the right, there is scarring. You can see here on the upper panel, low power and at high power. This used to be an open glomerulus. It's completely scarred. This one is almost completely scarred, and this one has a small segment of scarring. In the pi1 knockout mice, we had very little scarring, just a small amount of increased matrix here, and we quantitated this. We could see that the scarring was not statistically different from normal in pi1 and remarkably increased in wild type. So this gave some credence to the idea that pi1 could play a role in modulating fibrosis, but it didn't directly get at whether the presence or absence of pi1 could modulate existing scarring and play a role in regression of existing scarring. So if we're going to examine reversal of sclerosis, our experimental approach needed to be sound to meet the criteria of Maimonides. So we needed to start the intervention at a time of an established lesion. And ideally, we would establish the severity of the lesion by biopsy or by careful time controls of animal sacrifice at the same time and compare the course of lesions in the same animals with or without treatment. So the first model that we wanted to look at is one that is generally very important, maybe in addition to many of the disease states, that of scarring related to aging. And I've been asked if I know John Updike. This is a marvelous author. This is him as a young, dapper man, middle-aged, and now the senior scholar that he is. And I realized that perhaps I do not know him. Perhaps I should write him a letter of apology implicating that he has scarring kidneys. I'm just assuming, since he is a smoker, that he might. It's very likely that he does, but I do not know. This is a disclaimer. I have not violated HIPAA. I do not know the state of his aorta or his heart or his kidneys. But I would guess that as most Americans, particularly those who smoke, who are beyond their 50s, probably have a bit of excess scarring. So we wanted to study aging and the age-associated scarring that occurs in us, at least in western U.S. And to do that, we first needed to come up with a definition for aging. So this definition I also got from the literature, but from the poetic literature by Ogden Nash. And the definition here is senescence begins and middle age ends the day your descendants outnumber your friends. And I think maybe at this time it would be appropriate for us to have a moment of silence so we can all do the calculation and see whether we have reached this point or not. So it's easier for those of you who don't have any children. For those of us who do, it gets a little bit more complicated. It turns out that for the rat, aging-related sclerosis or senescence begins at 18 months. So we studied aging rats who had evolved spontaneously age-related sclerosis, and at 18 months, we had one group that we just followed for another 6 months, and we had another group that we looked at with high-dose angiotensin type 1 receptor blocker, ARB. And we monitored the scarring. Because we couldn't biopsy the aortas in these animals at the start point, we just had time controls of different groups, and we looked at aortic scarring, and we looked at glomerular scarring. Here's what the baseline scarring in a Masson stain looks at 18 months. In untreated animals, progressive, much more blue, much more tubular interstitial fibrosis by 24 months, and remarkably less scarring in the animals who for 6 months had received a high dose of ARB. When we then looked at the collagen content of these kidneys with the help of Jeff Davidson in Pathology, we could see there was a stepwise increase with aging, just as we saw increased tubular interstitial fibrosis and glomerulus, and this was decreased by ARB so that the final time point, these animals had less collagen than they did at the beginning. And we also found similar regression of the thickness and the collagen content of the aorta. This was interestingly linked to effects of pi1. Here are animals who had not been treated with in situ hybridization of the glomerulus, shown here, extensive signal, particularly localized to the areas of scarring. The animals who for the last 6 months of their life had gotten high doses of ARB, had no signal of Pi1, and had regression of the sclerosis that accompanied aging. I should point out that aging is not a remarkably hypertensive state in the rat. And because we have other ways of maintaining normal blood pressure with this very specific antihypertensive, these animals did not become hypotensive. So this was not a blood pressure effect. What about other models that are even more directly relevant to our human chronic kidney disease epidemic? We chose to study the hypertension-associated focal segmental glomerulosclerosis model of 5/6 nephrectomy because it reproduces so many elements of the chronic kidney disease downward slope in humans with hypertension, proteinuria, and progressive scarring. We induced the model in our rats. We followed them for 8 weeks. We treated them as if they were patients when they presented to our clinic with an appropriate IACUC-approved appointment. They underwent assessment. They had a renal biopsy, and the scarring in those renal biopsies was assessed, and they were matched into groups with equal scarring at the starting point that were no longer treated or not treated further, and animals that received varying doses of inhibition of angiotensin, either with an ACE inhibitor, enalapril, or an angiotensin type 1 receptor antagonist, losartan. We gave them a single dose of usual antihypertensive dose or up to a 4-fold higher dose, and then we looked to see what happened. Here you can see the different groups color-coded. The control, untreated animals, have ongoing hypertension after 8 weeks, which is when treatment started. And here the combined losartan, that's the ARB at low dose of enalapril, and all of the others, double, triple, quadruple, and just high dose of losartan or just high dose of enalapril, they all had decreased blood pressure. So they all benefited when the treatment was started and had less blood pressure. Interestingly, the proteinuria was very heterogeneous. Clearly, the control animals, shown again in blue, had ongoing marked increase in proteinuria, but the animal group that had the most decline in proteinuria were not the animals that had the most benefit with sclerosis. So in humans, we tend to think of proteinuria meaning that there is kidney injury, and that's very true, but it may not correlate precisely and absolutely linearly with sclerosis. Proteinuria can be due to non-sclerotic injury, as these studies would suggest. So here, each circle represents a rat, and we've expressed the sclerosis as percent change from their own biopsy. So at entry point, at 8 weeks, we had a biopsy. At 12 weeks, they had the sacrifice and examination of tissue, and you can see the variability inherent in the model where branches of the renal artery are ligated, and 225% increase in sclerosis over this 4-week period without treatment. And all of the treatment group, low-dose combo, double combo, triple combo, quadruple combo, quadruple ARB, quadruple enalapril, all of them had benefit. The best effects were seen in these animals, and I want you to notice that some of these rats were underneath this line, meaning they had a negative change. They had less sclerosis at the end point than they had at the beginning entry point. So here's an example of one of the animals that was not treated. At biopsy, there's well-established segmental sclerosis, there's tubular interstitial fibrosis, and 4 weeks later, this animal shows remarkable progression. More glomerular involved, and the sclerosis is more severe. Let's look at one of the animals who was treated and achieved regression. By study design, we have the same well-established segmental sclerosis, early tubular interstitial fibrosis, and here there is virtually no sclerosis, very few glomeruli involved, and less severe scarring in those with scarring, and the tubular interstitial compartment is proportionally beneficially affected. So what could be the mechanisms? We looked at some of the key possible mediators, including first TGF-beta. Transforming growth factor beta is a key molecule that we are very fond of at Vanderbilt because of Hal Moses' groundbreaking work in this area. And we looked at the mRNA expression in the whole cortex of the kidney. You can see, compared to normal kidneys from normal rats, there was a phenomenal increase in the 5/6 nephrectomy control animals without treatment, but there was no specific directional change that it was decreased by the treatments that achieved regression. This does not exclude a role for TGF-beta because the mRNA doesn't tell us the protein activation and interaction with the receptor at the glomerular cell level, but it indicated that perhaps this wasn't the major contributor to scarring. We also then looked at matrix metalloproteases that could be involved in breaking down matrix if their activity was increased. The two that are most germane to the glomerulus are MMP2 and MMP9. Here you can see that, as often happens with injury, the MMP is increased for MMP2, but obviously not enough to prevent scarring, and when we treated, it didn't increase further. That would explain regression of scarring. It actually decreased. So MMP2 could not be postulated to play a role in the regression. And for MMP9, we didn't see a significant change amongst the treatment groups. We also did zymography. You can see here from the whole kidney extract that we have a slight increase in MMP2 after injury, but it's not increased further. It's actually decreased when we treat it with high-dose angiotensin receptor blocker. And for MMP9, there's just a very faint band in all of them with no significant change. So the matrix metalloproteases also are not the key to the remodeling of scarring. What about PI1 and TIMP1? Let's look at TIMP1 first. It was remarkably increased when the animals had scarring, and it was significantly decreased, particularly by high dose of the monotherapy for the angiotensin type 1 receptor blocker, losartan, and with enalapril. And then when we look at PI1, we found that it was also markedly increased in scarring, as we would expect from our other data, and it was markedly decreased, again, by the therapies that mostly induced regression. But did it really affect the proteolysis? Well, we looked at the message and its localization and the protein and the activity. Here you can see at biopsy in control and animals that later were treated with type 1 receptor antagonists, the same level of expression of PI1 message, particularly in areas of sclerosis, with remarkable increase in the untreated animals, again, localized exquisitely to the areas where there is sclerosis of the glomeruli. In the animals that achieved regression, who were treated with high-dose angiotensin type 1 receptor antagonist, had no detectable message in the glomeruli. Looking at the immunostain, there is diffuse increase of PI1 in the tubular interstitium, and particularly accentuated in the early glomerular scars. Normal kidneys have very little PI1, just diffuse low-level immunostaining in the tubules, and remarkably augmented in the glomeruli with severe scarring in animals that had not been treated. And in those animals that had regression, they also, of course, by study design, had small scars with PI1 expression before treatment started, but after treatment achieved regression, they have no PI1 immunostaining in the glomeruli and very faint remaining PI1 in the tubular interstitium. And this correlated well with the plasmin activity, the key mediator by which we think that PI1 could be affecting or could be interacting with matrix fibrosis. Normally, there's quite a bit of plasmin activity in the kidney. It is markedly decreased when we induce the injury model, and when we treat animals with high-dose losartan and restore a normal architecture, we also restore plasmin levels towards normal. So these data all support that angiotensin PI1 axis is very important for mediating progression of glomerulosclerosis, and that if we antagonize angiotensin with very high doses, we could achieve regression of scarring, mediated at least in part by the effects of plasmin. But what about the effects of ACE inhibition and the type 1 receptor antagonist? Why did we use two drugs to inhibit the angiotensin system? Well, the reason we did this is because there are two drugs that clinically are available, and they have different intermediary actions. And it might be important to recognize what those actions are to optimize how we inhibit the renin-angiotensin system in our patients. Angiotensin is the molecule that converts inactive angiotensin 1 to angiotensin 2. Angiotensin 2 is the active ligand that can interact with the type 1 receptor. I'll tell you about in a minute. Is the classic receptor that mediates everything bad you think about with angiotensin. The AT2 receptor and the novelly described AT4 receptor. And this is where ACE inhibitors work. But when they are given ACE inhibitors, we also prevent the degradation of bradykinin. ACE inhibitors cause bradykinin to be augmented, and bradykinin, as it turns out, is a good molecule to have on board. It is vasodilatory, it's anti-inflammatory, so we might have beneficial effects from ACE inhibition from several things. Decreasing overall ligand formation and decreasing interaction with all of these receptors and augmenting bradykinin. In contrast, when we give an angiotensin type 1 receptor antagonist, we're not doing anything to the ligand. We're not increasing bradykinin, and we are blocking the interaction of this ligand with the AT1 receptor. And if we block this, all of this angiotensin that's on board is free to interact with the other receptors. So you could even have augmented interaction with a type 2 receptor. Well, does it matter? It certainly does. Here, I've shown you that AT1 is the classic receptor that mediates vasoconstriction, growth stimulation, and also matrix synthesis. And the AT2 receptor is counter-regulatory in many of these effects. It's vasodilatory, it inhibits growth, and it promotes apoptosis. And all of these could be beneficial, in theory, by decreasing injury, particularly apoptosis, which I think of as a very good way of removing activated injured cells before they create havoc, kind of like the bouncer at a hotspot nightclub. So not that I know anything about those places. This is from my children that I learn about these places. So the question then comes up, does the AT2 receptor potentially modulate tissue injury? In theory, we could say that it could. Could we even have a potentially increased AT2 action when we're giving the ARB by shunting unbound angiotensin to the type 2 receptor? If we combined ARB and ACE inhibition, could it be that it would be really nice to decrease the overall A2 ligand by giving the ACE inhibitor and then shunting to have more AT2 and less AT1 by adding ARB on top of that? Is it possible that A2 actions directly contribute to sclerosis? So we decided to test that, and we were able to get an AT2 receptor antagonist, and we compared that with the same study design as I've already shown you with the type 1 receptor antagonist and combined therapy. So these animals, again, underwent 5/6 nephrectomy. They were equal at 8 weeks, then treatment started. The controls had sustained hypertension. All of the treated animals had less hypertension. Proteinuria increased remarkably in the control. And look at that. The animals that just got AT2 receptor antagonists, they didn't have any decrease of proteinuria whatsoever. And it was abated mildly in the other groups. And then when we look at the sclerosis, here is the control, sclerotic glomeruli. Here is what we see with the AT1 receptor antagonist. Again, some animals had regression with completely open glomeruli. The AT2 receptor antagonist was similar, and actually it's slightly worse numerically for glomerulosclerosis than control. And if you added AT2 receptor antagonism to the type 1 receptor, you got an intermediate scarring with some early scars here. So we also looked at the collagen content, and you can see here again the normal kidney. Our 5/6 nephrectomy has a marked increase in the fibrosis measured by collagen content. The ARB regresses glomerular scarring and decreases overall collagen content, but this is not happening with the AT2 receptor antagonist, and with the combination, we prevent the beneficial effects of the AT1 receptor antagonist. And again, it is at least in part linked to PI1. So here we have all at sacrifice at 12 weeks, control animals with a lot of PI1. The AT1 receptor antagonist, just like before, there is no PI1 message. Very strong PI1 induced by the AT2 receptor antagonist, and intermediate levels of signal with combined. And the immunostain shows exactly the same type of pattern. Strong protein expression, very strong protein expression, no detectable protein here, and a low level but present PI1 immunostaining in combination. So we would say from this that if you're going to inhibit the renin-angiotensin system, it would be beneficial to have the AT2 receptor unblocked, to have it activated, and to inhibit the type 1 receptor. What about the capillary area? I've shown you a lot about matrix and scarring and collagen and the link of PI1. Can we investigate anything about the capillary area if that is increasing also? This is what we want to see, if there could be lengthening or branching. And looking in the literature, an elegant morphometric study done in Denmark by Jens Niengaard, both in rats and in humans, he showed that the enlarged glomeruli that happen, that don't have scarring in some disease states, are not by ballooning up and aneurysmal dilatation. This increase in glomeruli that happens in some disease states in the non-scarred glomeruli is by lengthening and branching of the capillaries. So we decided that we would investigate this, and our schema is shown here, where we think that the scarred glomerulus could resorb and could become less by mechanisms I've gone over, and you could then have the remaining capillary loops lengthen, have some branching in areas where there was scarring, and you could measure this if you could serially section through the glomerulus. And the way we did this was by confocal microscopy. Ellen Donnert in my lab was able to achieve this. And here we have a red matrix-type stain going through a normal glomerulus. You can see the complexity of the branching of the capillary lumens. The green is a specific stain that allows us to identify the podocytes. And overlaying these stacked images, we can identify the branching and compare it to glomeruli from an animal with progressive scarring. This is, well, it's not projecting as nicely here as on the screen, but this area is scarred. Here are some large channels that are showing up here where we have a few open loops going through the glomerulus. And in animals that have achieved regression, we could see less scar, as by definition, but the capillary branching pattern to our naked eye looked like it was more complex. We didn't have these few open channels of lakes going through the glomerulus. So to be able to look at this in detail, we took very high resolution images that are shown here with the normal. Here's an area of sclerosis and these open channels. And Ben Scruggs, a biomedical engineering student, now a graduate student at WashU, and my fellow Yiqing Zhu and I overlaid these images and determined if there were branch points or not. And then to analyze all of this data, we used a novel approach I came across in some very strange archaic literature called graph theory analysis. And here you can see with each little symbol representing a branch point, and I should point out that the lengths of the lines between do not represent the lengths of the capillaries. It's just to be able to fit the representation in on the slide. This is half a glomerulus, this being the arteriole, and this being the midpoint. So each of these are branch points, and each of these large connectors are channels going through the glomerulus. And comparing this, and these dots are just shown bigger because there's so few points to make the slide proportionally the same. There are many fewer branch points in the sclerotic glomerulus, the few open loops that remain, fewer branch points, fewer open capillary loops, and fewer channels going through the glomerulus. And this could all be mathematically addressed. So when we then compared the normal, again on the left, to regression animals, we could see that here we had a restoration with a significantly increased compared to progressive animals number of intersects and vertices, branch points, and channels going through the glomerulus. So this supported that capillary branching was actually happening. It didn't just look better to the blinded pathologist's eye. You could actually express it mathematically. So how could that be achieved? Well, we know that the parenchymal cells interact in key ways, and that the podocyte excretes many growth factors that are key for endothelial cell growth, including vascular endothelial growth factor and angiopoietins. So we wondered if podocyte injury affected endothelial cell growth. That was already to some degree known from other studies, but our next question was very novel, we thought. Could this interaction be modulated by angiotensin inhibition? So to look at these studies, we looked at glomerular endothelial cells grown in culture. We had primary podocytes growing, and we injured them with a toxin that's very specific to podocytes. When given in vivo, it causes a focal segmental sclerosis, and it also is an established injury model of podocytes in vitro. And then we did or did not treat these injured podocytes with angiotensin type 1 receptor blocker. We took the conditioned media from these podocytes and added to our endothelial cells and saw how they were able to sprout and proliferate. So here is our primary cultures of glomerular endothelial cells showing the normal branching. This is what they look like when we give supernatant from pan negative. That's normal podocytes. They grow more. And we did Westerns and showed that this media contained a lot of VEGF, vascular endothelial growth factor, and angiopoietin 1. Then we gave them supernatant from pan-injured podocytes, and they did not grow. And we didn't have VEGF or angiopoietin in this media. And when we gave them just pan, it didn't have an effect on the growth because this is an epithelial cell-specific toxin. And when we gave them media from injured podocytes that were also treated with losartan, we restored their ability to grow. Losartan given to normal podocytes increased growth even more, and losartan by itself had minimal effects. And this is shown quantitatively here for the branching. The normal cells, podocyte supernatant from normal podocytes induces growth. When they're injured, there is no growth. And here, the important thing, we restore the growth when we treat the injured podocytes with losartan. And we had similar data for proliferation. The exact same mediators are present. And importantly here, injured podocytes treated with losartan, that restores their ability to mediate growth. And we thought this was fine and wonderful. And we looked at some signal transduction mechanisms with the help of Ambra Posey and Roy Zent, and found that these effects with the losartan of the injured podocytes was largely mediated by restoration and increase of P38 MAP kinase, which is a key signaling molecule that helps to make it possible for the endothelial cells to sprout and proliferate. And we also found increases in ERK and AKT, which I will not show you. And we have to thank the reviewers, as often is the case. They made it possible for us to do an even better study because they said just because VEGF and angiopoietin are up when there's no injury and down when there is injury and restored when you treat with losartan doesn't mean that that causes it. So we got to do some additional experiments and antagonize, in this case, with antibodies for the VEGF interaction, antibodies for the angiopoietin, and combined antibody for the VEGF and the angiopoietin, and we could then prove to our satisfaction and the reviewer's satisfaction that indeed this is mediated by VEGF and angiopoietin. So from these studies we would say that glomerular endothelial cell sprouting and proliferation are decreased with injured podocytes. And importantly, the angiotensin receptor antagonist restores the podocyte ability to promote endothelial cell growth. And we think that this promotes potential remodeling and angiogenesis after injury and could be a key novel way in which angiotensin inhibition has beneficial effects in chronic kidney disease. Up to this point, I've told you about hypotheses that could be generated and explored from known existing data by reasonable people. But we wanted to look at the unknown. And I'm going to show you now in the last little bit here some novel data that we're excited about where we have used a proteomics approach to look for things that we did not know about and could not possibly have imagined. To look at this, we wanted, first of all, to see if proteomics could actually detect sclerosis. Can sclerosis in individual glomeruli be distinguished by laser capture microdissection proteomics? Is it as good as a renal pathologist in looking at that? And then a scientific question, we wanted to know, in these kidneys that have a focal distribution of the scarring, the glomeruli that aren't yet scarred, are they proteomically the same as normal glomeruli, or do they already have activation of prosclerotic pathways? And with Richard Caprioli and Jonathan Hsu, we embarked on these studies. This is our setup. We used laser capture microdissection, and Ellen Donner in my lab was able to dissect out the individual glomeruli. This is the glomerulus. You can see here we dissected it, and then here we have the tissue that is used for mass spec. We were able to get a mass spec from pooled 5 sections of glomeruli, and we pooled them together into normal glomeruli from normal kidneys, and from the 5/6 nephrectomy kidney, those glomeruli that looked normal, the non-sclerotic ones, in a sclerotic setting, and the sclerotic ones. And when we look at these mass spec profiles, we could identify about 700 peaks. I have to hasten to say that this type of proteomics does not detect very large molecules well. It doesn't detect receptor-bound molecules well, but it did detect about 700 peaks. So we thought that was great, but then we needed to analyze it, and UShare and Biostatistics helped us with this, and we were so excited about these results because the proteomics was very distinctly different, the pattern from normal glomeruli versus sclerotic. That was good. It really could tell the difference. This is at about a 99.8% classification accuracy. And it also could tell the difference between the glomeruli in the same kidney that were non-sclerotic and sclerotic. And this also had a very high classification accuracy. But what was very exciting conceptually was that normal glomeruli from a normal kidney and those that didn't have sclerosis yet in the injured kidneys, they were also statistically highly different. So statistically exploring this, we can see here that these all are statistically different. The normal, the non-sclerotic, and the sclerotic, these are slightly more related. So we thought that this was fun, but now we wanted to know what are those molecules that are differentially expressed. So we used the David Letterman approach, a top 10 of which molecules are those that are most informative in separating out our categories statistically. And when we looked at this, we run out of tissue with the remnant kidneys that we have, but we were able to identify one molecule that was highly significant in informing the classification difference, and that is thymosin beta-4. I was told by UShare and by Jonathan Hsu, this is the molecule. I said, thymosin beta-4, that's very interesting. Now I know a lot more about it. It's not a molecule that was on our radar in relationship to sclerosis. It turns out it's a highly conserved G-actin sequestering protein with a wide range of functions. It has roles in wound healing, apoptosis, angiogenesis, cardiac repair, and endothelial cell differentiation. And can you imagine how excited I was when I found out that in other cell culture systems, it had been found to increase PI1 expression, and there also was some indirect evidence linking its breakdown product to the renin-angiotensin system. So first we wanted to then establish if thymosin beta-4 really was increased in the tissue. We had a mass spec profile. Was it increased in the glomeruli when we looked at it? So we did immunostaining. We didn't find thymosin beta-4 in the normal glomerulus, but shown in brown here, it's expressed in many cells in the scarred glomerulus. The red are macrophages, and a few of them had thymosin beta-4, but most of them were negative. And by serial section and double staining, and also looking at concomitant in vitro systems, we determined that the podocyte in this model did not express thymosin beta-4 by Western blot. Here are controls. And the glomerular endothelial cells expressed a lot of thymosin beta-4. So then we wanted to look at how this might function. We had established that thymosin beta-4 could be a marker of the sclerotic process. Could it also have a role, a causal role in sclerosis? So we used siRNA to knock down thymosin beta-4 expression. You can see here that thymosin beta-4 successfully was knocked down by siRNA. The scrambled construct had no effect. And then we stimulated with angiotensin II, or we stimulated with angiotensin II, our profibrotic stimulus, in the absence of thymosin beta-4. And what do you think happened? Well, look here at the PI1 expression. When we stimulate with angiotensin II, PI1 is markedly increased, but not if we give siRNA. And this data is shown here. So angiotensin II increases markedly the PI1 expression, but it has a dependence on the presence of thymosin beta-4, implicating that it might not just be a marker of sclerosis, it could be a novel target that could actually be important for mediating the sclerosis. So I think that these studies are wonderful for the rats and mice of the world. I'm sure that if any of you have rodents that you care about that have chronic kidney disease, you'll bring them to our lab because we can do something about their chronic kidney disease. But I want to, in the last slide, show you proof of principle that it also is important for humans as well. These are studies from the University of Minnesota where patients had diabetic nephropathy, as you can see here, a glomerulus with tremendous expansion of matrix, and they underwent cure of their diabetes by getting a pancreas transplant. And then in those days, the people at University of Minnesota had 5 years of funding, and after 5 years, they repeated biopsies on the same patient, and there was no change. And I'm so glad that in those days it was possible to get yet another 5 years of funding to follow these patients. And look what happened. The same patient, 10 years after the diabetes was cured, the only treatment has been supportive of keeping the transplant working. The diabetic nephropathy has regressed and reversed. So this is proof of principle that sclerosis can be reversed in humans as well. Our goal is to change the deleterious events that are happening in the glomerulus, to shift the balance from collagen synthesis to degradation, to have an appropriate balance of cell division and cell death, so that we can achieve for all of our patients less glomerulosclerosis, interstitial fibrosis, and more repair and healing. My very last task is to thank many people. First, I want to thank somebody who has not been involved with these research projects. There are two people, the late Alan Glick, whose fellow I was, who taught me to love the kidney morphologically, and Dr. Robert Collins, who was my teacher since medical school and has been my best friend and mentor since, and made me realize it could be so fun to be a pathologist. These are the people who have directly contributed to these research studies. Yakuni Chikawa, whose fellow I once was, my wonderful collaborators, Valentina Kahn, I speak with almost daily, Doug Vaughn and Nancy Brown, who've been wonderful in giving me ideas and directing and collaborating on the PI1 studies, Peter Mundell, Michael Medeo for cell culture, Umbra Posey and Roy Zent teaching me that signal transduction was not a dirty word, it was possible to do with their help. I've told you about Richard Caprioli's wonderful contribution to the mass spec. The people who are currently in the lab, most importantly Lee Jin Ma and Ellen Donner, because they have put up with me and all my crazy ideas and energies and sometimes lack thereof for many, many years. The other current fellows and many postdocs, research fellows, students who've been in the lab, and Brent Weidman and Jean McClure for making my slides work. Thank you very much.
I'm sure you'd be glad to take a few questions.
I'll be happy to try to answer your questions.
Thank you for that elegant presentation. I wanted to ask you about the impact of pregnancy on the progression of chronic renal disease. I mean, one would think that pregnancy could be a very dangerous state because of the increase in renal blood flow, increase in intraglomerular pressure, the decrease in renin, aldosterone, and the system. But yet, I don't know that there's any clear evidence that pregnancy is associated with progression of chronic renal disease in those women who enter pregnancy with that problem. We also stop ACE inhibitors. There's potential for preeclampsia. What's your opinions about this?
The question relates to whether pregnancy, which has many activations of potentially deleterious systems, including increased blood flow, increased renin-angiotensin system, does that exacerbate chronic kidney disease? I have written a chapter about this for a renal pathology book that knows more than I do about this because, as you well know, it's rare that pregnant women are biopsied because it is not a totally innocuous procedure. There can be temporary exacerbation of proteinuria during pregnancy, but for nearly all patients, once the patient delivers, renal function returns to pre-conception levels. The main consideration is that the risk of preeclampsia secondary to the mild chronic kidney disease that exists is increased, and that may be an exacerbation of functional aspects related to the disease. The other key aspect is that sometimes lupus can flare during pregnancy, and if that happens, then there could be acute deleterious events related to more active lupus, but not typically an increase of the scarring events. And it's very interesting to think about what are the counter-regulatory elements that allow most women to have some potentially deleterious adjustments in their renal function and yet not have progressive scarring. First of all, gestations are 9 months or shorter. And there are some counter-regulatory events of vasodilatation that could offset some of the potentially deleterious questions. But we're very fortunate that pregnancy does not set in motion multiple cascades of chronic kidney disease in most patients. Yes, George? How it is removed? With great care. You remove one kidney rather easily. A simple unionephrectomy is not that difficult to do. The remaining kidney, it's very complicated surgery involving ligation of branches of the renal artery. And the branching system is such that you have to be very careful and very patient. And I'm very lucky that I now have people whose hands in the labs are much better than mine, particularly Li Junma, to avoid bleeding and catastrophic injury. Other people, because that is technically very difficult to do, have tried to remove the portion of the remaining kidney, the 2/3 of the remaining kidney, by cautery or by tying off the poles. And it seems interesting that it's necessary to have the remaining infarcted ligated tissue to have the fastest progression, most hypertension. We want the most serious model, not up to the point of malignant hypertension. So we do it with ligation.
So is there a dark side to inhibiting angiotensin receptor 1?
Well, in patients who don't have a normal sympathetic nervous system, a normal arginine vasopressin system, they could be hypotensive. And in all patients who already have chronic kidney disease, there might be side effects of, particularly with ACE inhibitors, or to some effect with ARB, of hyperkalemia. The doses that Nancy Brown has used when adding aldosterone antagonism, which I didn't have time to show data that she mostly is the lead person on, showing that aldosterone antagonism can also affect sclerosis through a PI1 mediated mechanism, particularly could make hyperkalemia a problem. But for most patients, if potassium is monitored, having higher than usual minimal antihypertensive doses of angiotensin inhibition does not cause deleterious effects. is a remarkably safe pharmaceutical agent.
I believe the arteriolar complex in the glomerulus is a unique vascular system.
Yes.
What is the role of that system in enhancing glomerular function or glomerular function?
So the question relates to the unique anatomy of the glomerulus, which has both an afferent and an efferent arteriole, and how that could allow you to regulate glomerular function. This means that you can control the sphincter going in and going out of the glomerulus, and by applying simple garden hose physiology, we can understand that you can then regulate the transcapillary pressure within the glomerulus somewhat independently of systemic blood pressure. So in studies that Ichikawa did when I first was his fellow eons ago, and that Tina Khan did, they showed that ACE inhibitors particularly dilate the efferent arteriole going out. And you can imagine by thinking through the garden hose physiology that particularly would cause the pressure to drop within the glomerulus much more so than in the systemic blood pressure. So that has been recognized and has been studied for decades by Barry Brenner at Harvard as being one key mechanism contributing to the efficacy of ACE inhibitor. Our interest then went a step further because when we gave super high doses of ACE inhibitor, we had further beneficial effect, and it wasn't because the pressure dropped further within the glomerulus, but it's a key element. And some decades ago, that was the focus of very much elegant investigative work, both from physiologists and from renal micropuncturists in medicine.
So I'm wondering if there's any other more novel therapeutics possible coming on, because it's interesting that GPCRs actually sometimes dimerize and sometimes heterodimerize. In particular, in the angiotensin system, it's known that receptors heterodimerize.
Yes.
And that changes their pharmacology.
Exactly.
Is there anything coming along based on that, or specific drugs that will target that?
So we have a question about whether there are new drugs coming on board based on new insights and how some receptors may function. They may dimerase, and that could change their functionality and their response a lot. I don't know of any new drugs based on the AT1 receptor dimerization and modulation of functionality, but there's now recognition that renin could have a direct role other than transforming angiotensinogen to angiotensin, and there are pharmaceutical drugs based on antagonizing it. There are pharmaceutical drugs based on interacting with breakdown products of angiotensin 1 through 7. And there are pharmaceutical companies based on a peptide that turns out is a breakdown component of thymosin beta 4, which may be antifibrotic and is modulated by ACE. So there are many things coming on board, but we don't yet have more specific manipulation of the receptor functionality. I think so far we've been disappointed with attempts to try to antagonize other profibrotic molecules. We have worked with antibody to TGF-beta and found surprisingly that the higher dose was worse than the lower dose, and we were really completely blinded in this. And we think that is because the higher dose actually prevented some of TGF-beta's immunomodulatory effect. So we had many more macrophages coming into the tissue and injury related to that, and that's been reproduced elsewhere. And initial studies in scleroderma with antibodies to TGF-beta conducted by Genzyme did not show a measurable effect on dermal collagen. But they have started with a clinical trial now on anti-TGF-beta in aggressive focal sclerosis. And we are excited about some aggressive therapies looking at combination of angiotensin inhibition and PPAR-gamma, that is the thiazoldienediones that are used for diabetes. It turns out they also affect sclerosis, and we have worked with a clinical trial to test more novel combinations. I'm hoping we will find more out about some of these new molecules to move into more dynamic therapies.
Thank you, Agnes. We're going to have to bring the discussion to a close here. I invite everyone to join us at the reception in the lobby immediately following, and there will certainly be time for additional enthusiastic discussion there.
Thank you very much.